request Dr. Kumar sir, please deliver your talk. So, sir will speak what are the new things in our dacryology.
Good morning. Thank you, Jayant, for making me a part of this course. I'll be speaking on some of the newer approaches in management of lacrimal diseases. We'll talk about some entities in congenital nasolacrimal duct obstruction, like some of them not so new but used more often now, like inferior turbinate in fracture, balloon dacryoplasty, and the endoscopic assisted probing of late has become a very useful tool for management of congenital nasolacrimal duct obstruction, almost becoming a routine in the more difficult cases. For the acquired obstructions, use of botulinum toxin for punctal or canalicular obstructions has become much more common. Canalicular obstructions, many of them can be tackled with Sisler trifines, and conjunctival DCR has become more defined because of new tubes and new techniques which have already been elaborated upon by Amrita. For acquired nasolacrimal duct obstruction, endoscopic DCRs have become more in vogue with better results than were reported earlier, approaching the success rates of external DCR. The non-endoscopic transnasal DCRs have also been used quite significantly now, even in pediatric cases, and transcanalicular procedures, including recanalization of the nasolacrimal duct, are also important procedures now. In the management of failed probing, a repeat probing is often carried out after an interval of minimum of 6 weeks, and inferior turbinate fracture and balloon catheter dilatation have become more important tools in these cases, and virtually all of these cases would now be done under endoscopic control. So the important thing about inferior turbinate anesthesia is that you do a vasoconstriction first by nasal packing. We learn from our ENT colleagues that they use very high strengths, up to 1 in 5,000 or 1 in 10,000. And what is important is to realize the anatomy of the inferior turbinate, which then needs to be rotated away so that the inferior fossa becomes much more accessible and visible and allows you a direct visualization of the probe and manipulation of the silicone tubes if you want to carry it out. Balloon catheter dilatation has been there for quite some time, but has been in use in specific cases only over this period of time. And it is used both in previously failed cases as well as primary cases. The advantage is that the dilatation forces are directed radially rather than longitudinally, and they are more effective and produce less tears. Now, the success rates of 77% versus 84% intubation are not that great, and they are costly. So the use has remained rather selective. So balloon sizes of 2 and 3 millimeters are available, the larger one for the older subjects who are more than 2.5 years old. And the 2 cycles of balloon inflation are carried out both at a distance of 15 and 10 millimeters. And this is the device where you have an inflation which is done by air injection, the pressure you can make out, and this is the balloon that dilates. And at the defined pressures that we spoke about, this dilatation is carried out after the probe and the balloon is in position. And this is how the pressure is maintained for the required duration, and then it is removed. Now, nasal endoscopy is very useful and is probably the most important gain in probing, which has improved success results in complex cases to very close to 90-95%. As you will see here, 94 to 97% is a very high success rates, even in complex cases where the opening of the probe is not directly into the passage but maybe submucosal, and all cases where there are nasal cysts or other associated pathology can be directly tackled now. Let's look at an example now. This is a probe being passed, and rather than being blind, we see the inferior turbinate, we rotate it away so that now the inferior fossa is much more spacious. We can see that the probe is pushing the mucosa rather than coming in through a obstructed nasolacrimal duct opening. So we have to open it with a sickle knife, as you're seeing here. And once we open it with a silicone knife, with a sickle knife, we're able to see the probe actually physically present there. So now we are much more sure of what to do in these circumstances, which are complex. And once we have created an artificial opening, it is important to retain a stent in position, because otherwise it would fibrose. So silicone intubation is carried out, which is also much easier under direct visualization of endoscopy. For the acquired obstructions, punctal stenosis has seen a sea change where our conjunctivodacrocystorhinostomies have dropped down almost 500%. And we do hardly a couple of conjunctival DCRs in a year now because of the availability of botulinum toxin. 2.5 units is generally used, injected transconjunctivally under topical anesthesia into the palpebral lobe of the lacrimal gland, and the results are very gratifying, with almost 60 to 90% patients being significantly better. And this is true both for anatomical obstructions of the upper lacrimal passage as well as functional epipora cases, where some of them a surgical procedure may be avoided. The effect usually for our patient is mean of about 6 months. Usually about 3 injections are needed, and many of them would not complain after 3 injections or will require much less frequent injection of Botox and get a permanent result. So transient ptosis is the only common complication in about 8% cases. Other complications are rare. This would last only about 4 to 6 weeks. And we have done over 200 cases now, and with very high success rates of over 90%, with an average duration of 6 months. Now, the obstruction in the upper canaliculus or punctal obstructions, there are a number of procedures, but the ones that are more commonly used are punctal opening with plugs or intubation, snips or snips with intubation. Now, the availability of perforated punctal plugs from FCI is one very useful method, which allows the drainage to take place while the newly opened punctum can remain patent. Snip procedures are relatively less often used now, but in some situations they are very useful. Like you observe here, we can hardly pass our probe to any depth. Now, many of these cases would not work with a single snip as well. If it's just a punctal stenosis, then a single snip would work. But in cases like these where we found no patency after the single snip, a 3-snip procedure still may have relevance. So here we have given a horizontal cut, and once we join, after the first 2 millimeter vertical cut, this horizontal cut along the direction of the canaliculus is given, and then the two are combined together to create a 3-snip. Fortunately, in this, after the 3-snip, we were able to find patency and carry out an intubation. So this is the completion of the 3rd snip, and you can see that the probe can now be passed so that intubation is now possible. So of all the techniques for canalicular blockage, cisplatin seems to work well for middle canalicular obstructions, single obstructions, usually at about 4 to 6 millimeters. And this cisplatin Once you passed, you remove the outer shell and you allow the trephine to go through the obstruction and then carry out an intubation. This has reasonably good success rates for isolated single obstructions at about middle of the lacrimal canalicularis. So conjunctival DCR has fortunately been covered well by Amrita, and we will not need to go into the various options, advantages, stop-loss tube, indigenous tubes that we get it made, and the technique and the newer approaches of direct passage. So we will avoid these videos as well. Transcanalicular laser DCRs and endonasal DCRs have also given a significant change in the scenario of surgical management. So the use of silicone intubation, mitomycin C are points which are debatable, but increasingly in failed cases, mitomycin C is consistently used with good advantages. Endonasal has become much closer to external in its results. Thank you very much.